So the question that I know you're all dying to ask is, why do we need to have a randomized controlled trial to figure out the demand curve? We know that people get healthcare, so we know that there's some quantity of healthcare out there, and we know that people pay prices for healthcare, so we know we've got prices, you got quantity, you got prices, plotted on a curve, done deal. There's a reason why, however, that doesn't work that well in practice, and it's because of insurance, which we haven't talked about in great detail, but it affects a lot of things in the healthcare market, and it certainly affects demand for healthcare. So let me share a screen for you. Okay, so let's say that, let's suppose that you're a sicker kind of person. You know that you're going to need more surgery, you know that you're going to need more medicine, whatever. So that has really two effects. The first thing is, of course, you're going to need more healthcare. And secondly, you're also going to choose to have more generous insurance because that will help you to pay for it. So you choose a plan that will cover most of your costs. What that means is that effectively you're going to face lower prices because you've got this really generous insurance. Maybe the hospital would have charged you $5,000 for something if you had worse insurance, but because you've got this fancy plan, you only have to pay $1,000. So effectively, you face lower prices than somebody who has cheaper insurance. Now, on the other hand, if you are generally a healthier person, you are going to do two things. You're going to use less healthcare because you're healthier, and because you're healthier, you're not going to choose as generous of insurance. So this is why we have a problem when we use empirical prices to try to figure out a demand curve for healthcare. Since people face all of these different levels of prices, it's confounded by the type of insurance that you have. So who's going to be facing these low prices? It's going to be all these folks who are sicker and are in more generous insurance coverage. That also means that they're going to need more healthcare. So correspondingly, on this quantity curve out here, this is the demand measured. So the demand measured for people who are facing low prices for healthcare is obviously way out here on the quantity demanded curve because they're sicker and they need more healthcare. Now, who's going to be up here facing high prices? It's going to be the people who generally are healthier and they don't need as much healthcare. And so they've chosen a health insurance plan that doesn't cover as much. So those who are facing high prices are all the way back here on the quantity demanded curve. This is quantity for according to high prices. So the issue, in other words, is that you've got not just a difference in prices, which is what we need to get the demand curve. We also have a difference in the people that we're looking at. So it's sort of like we're polling the people who are generally pretty healthy for the low price section of the demand curve, and then on the next section of the demand curve, we're polling people who are comparatively sicker and they would have needed more care no matter what. This is why this DT, which stands for demand true, or this is the true demand, or the real underlying demand curve. What this curve represents is if everybody paid exactly the full cost of their healthcare without any insurance at all. That's what this corresponds to. So the real demand curve looks like this, but because of this distortion in the market, we've got different groups that are responding at different points in the demand curve, and that's why it's slanted more sideways. That emphasizes the need for randomized experiments. There are two really good ones out there. The RAND health insurance experiment took place a long time ago in the 1980s, I believe, and it randomly assigned health insurance plans to different families in the United States, in I think across 6 different cities and maybe 2,000 families. So it randomly assigned insurance coverage that was more or less generous in order to get at this idea of what's the demand curve when the only thing we're changing is the price. Oh, and the other one is the Oregon Medicaid experiment. That is much more recent, and that happened because of the way that the state of Oregon decided to roll out its Affordable Care Act expansion of Medicaid. They randomly generated people who, they randomly identified people who were eligible and offered them insurance coverage, and then compared them to folks that, that were in the control group. So the RAND Health Insurance Experiment, 6 cities, 2,000 families, and they had different co-payment groups. So in one, healthcare was free, so effectively facing no cost at all for your healthcare. Sounds nice. And then these other co-payment groups, so 25%, 50%, 95%. What's meant by co-payments here is how much of your healthcare you have to pay for as the patient compared to how much you have to pay for compared to how much your insurance has to pay for. So if you have if you're in a 25% co-payment group, then when you go to the hospital and you incur a fee of $1,000, if your co-payment is 25%, then you are going to shell out $250 on your own. If you're one of the sorry folks who were in this group, you had to pay for 95% of it, which means that you'd have had to shell out $950. So this study tracked how much healthcare they demanded, that's the quantity, in each of these co-payment plans, and this is the price. So the co-payment acts as the marginal cost that each family faces when they're buying care. By contrast, the Oregon Medicaid experiment was a bit different. They compared a couple of groups of low-income adults because that's who became eligible for Medicaid under the Affordable Care Act expansion. It was targeted towards lower-income adults, so that's the study population we're looking at here. And they looked at Medicaid lottery winners compared to lottery losers. So Oregon created this lottery, and if you got a high likelihood number, then you were offered healthcare coverage, and if you did not, then you were not offered healthcare coverage. So you have two groups that are otherwise similar. One gets offered healthcare. One gets offered health insurance. The other does not get offered health insurance. So the lottery winners were eligible to apply for this public insurance. And those folks then compared to, so these lottery winners, they face lower prices for care compared to the lottery losers who continued to presumably pay out of pocket or, let's just say 100% of their own healthcare costs, whereas these folks got a lot of stuff covered and it would have been a percentage much, much lower than this. Lottery losers may have been able to get Medicaid, or were not able to get Medicaid, but they may have been able to get other kinds of insurance, maybe through the ACA exchanges or just private plans. So what they find? Good news for economists. I know you're all worried about that. Healthcare demand curves do, in fact, slope downward. This was actually a pretty big deal. Back in the, 50s and 60s, it was not really all that well established that the healthcare demand curve sloped down at all. The idea was like, well, it's just you need the healthcare that you need, and so you pay for the healthcare that you need, regardless of price. Which implies that there's really no point in setting prices. Like, price doesn't really serve a function in healthcare markets. That would be a real problem if you wanted to use markets to organize your healthcare system. So the economists found that was not the case. So price changes did, in fact, affect demand for healthcare. And of course, we know what that's going to look like. Quantity demanded, quantity demanded for more of it, and quantity demanded for less, based on prices. High prices, low quantity demanded. Low prices, high quantity demanded. Bada bing, bada boom. The demand curve is downward sloping. So these studies looked at some different measures of care. There are lots of different types of care that one can get. And one of those ones was outpatient care. They also looked at inpatient care. So outpatient care tends to be less severe. You go because you had some sort of an accident, you've got a cough, you want to get that taken care of, things that are not, generally speaking, life-threatening. Inpatient care, is either something that's more serious, more life-threatening, or it just requires more supervision, so invasive surgeries and things like that. Emergency room care, obviously super important. That's something that is emergently life-threatening, that you'll need care for right away. So in the Rand Health Insurance experiment, they found that, unsurprisingly, as patient cost sharing increases, so as patients paid for a higher amount of their care, so the 95% copayment folks up here, the 25% here, and then down there was where it was free. So as patient cost sharing increases, the number of episodes of outpatient care decreased. So that's going to be something along these lines. At these really high prices, the quantity is way back here. Something along those lines. And that holds for both acute and chronic conditions, which is helpful to inform the way that we design health insurance. So you can see that here. You could plot these numbers out and get the demand curve yourself. So you look at, at this price, 25% of the copay, total quantity demanded is 2.32. You could plot that out. I recommend that you do that as an exercise, just so you can see that, what do you know, it does actually downward slope. And this is how demand curves get written out. And the same thing happened in the Oregon Medicaid study. The lottery winners had more outpatient visits than the lottery losers. Inpatient care, as you might expect, well, I guess you could imagine differences between outpatient and inpatient care. So outpatient care, is, what's in that category. It's a bruised knee, your kid has a cold, etc. You need to go see someone. Maybe it's just an annual preventive checkup. That kind of stuff tends to be less severe. You can imagine that demand for that kind of care is much more sensitive to prices. If you had a runny nose and you were thinking about going to see a doctor about it, if it was $10, maybe you'd go see it. But if that doctor was charging you $350, you might pocket the difference and wait it out at home, or you might run to the pharmacy and just get some Robitussin or whatever it is that you use to treat runny noses, and then save yourself $340 and whatever, spend it on something that you like better. Maybe Bose headphones or something like that if you get them on sale. So you can imagine how that's different from inpatient care, where this tends to be a little bit more serious. There's a little bit less discretion on the part of patients over inpatient care for more serious conditions. So unsurprisingly, these studies, both the Rand Health Insurance, the Rand Health Insurance experiments found a slightly downward sloping demand curve. It's going to be flatter. So the demand curve for price, quantity. So for outpatient care, we found that it was like fairly responsive. So demand, outpatient. But for inpatient care, they were finding that it's a little bit steeper demand for inpatient care. In other words, a fairly big change in price doesn't change the quantity all that much for inpatient care. Now, in the Oregon Medicaid study, they actually didn't find any significant difference between lottery winners and lottery losers, which again suggests that there's a good bit of inelasticity for inpatient care. For emergency room care, you've got these really important conditions, and in the Oregon Medicaid study, they found that there was not a significant difference in ER care for the lottery winners versus the lottery losers. So importantly, even for emergency room care, most urgent type of care, that things that are whatever you're bleeding, those on the highest copayment plan in the Rand Health Insurance experiment were less likely to buy care. That is kind of crazy to think about. So this is definitely the one case where you'd expect to see pretty much a completely inelastic demand curve. Like I got into a car accident, my arm is busted, and my whatever, feel these funny chest pains, etc. You'd think that under all circumstances, you're going to get care no matter how much, whether you're way down here in price or whether you're way up here in price, you need to go get an ER visit. But in the Rand Health Insurance experiment, that they found that those who face these higher prices were less likely to get care, which says that the way that we set prices in healthcare makes a big difference for the type of care that people choose to get. And I'm going to pause there for a second.